Good morning. My name's Tim Keenan. I'm the president of the Oregon Association of Orthopedic Surgeons, and we're delighted to have you all here for our spring meeting in coordination with the administrative group that's here as well. We have about 20 physicians signed up and about 60 administrative staff signed up, and we're delighted to have you all here. The lineup is beginning with John Tung talking about the value of orthopedics. As you all know, we're under fire for whether what we do is of value and what does it cost, and John has a new innovative way that we have looked at the value of orthopedics. The second section addresses those nettlesome things of motor vehicle and workers' comp issues. We have two attorneys here, Ryan Jennings and Jeff Thayer, who are I've asked to address what are the challenges we have, what need to go in the doctor's note, what are the things we need to know on the phone in order to make those interactions easier. And last but not least, Dr. Nichols, an orthopedic surgeon who's going to address what we all will come to love and hold dear to our hearts, ICD-10, which, if promises are kept, will be on our doorsteps in October. So first, John Tung, our local visiting fireman here in Tualatin, past president of the American Academy of Orthopedic Surgeons, who's going to talk about the value of orthopedics. John.
Okay, thank you, Tim. Welcome, everyone. Thanks for getting up early on a Saturday morning to come and try to learn something about how to make our practices better for our patients and still come out with a profit margin that's reasonable. We are under fire. When I joined the presidential line of the Academy 5 years ago, I started getting these news clips on a weekly basis from our staff who collect media coverage around the country, and it just gets absolutely overwhelming how negative the coverage is about who we are and what we do. And so I began wondering, how we could respond to that, and that's what I want to present for you today. What we do is viewed by the media as being very expensive, and I've had people come up to me in social conversations talking about how expensive it is to have a total knee replacement, for example. And in my heart, I knew that it also had a great deal of good, but we were unable to in any way articulate that. It reminded me of the old statement that in God we trust and all others should bring data. So I'm going to show you some data today. This is a talk that I gave at the Academy in Las Vegas 2 weeks ago. I think Clyde Ferris was the only one that, and I don't see Clyde here today, so I don't have anyone that has to sit through this twice. So what we did was we hired a team of health economists to work with us. The problem we have as surgeons is that we think that everything that we study has to be a prospective double-blind clinical study. You can't do that for this question. It's not feasible economically or logistically or in terms of any timeline. It'd take decades to put the data together. But the economists don't have any problem with that. They could take different sets of data, crosswalk it, and come up with estimates that are far better than anything we have, but we just have never thought about working with them. The thing I'll tell you about interdisciplinary research that I learned over the last 5 years is that it's very exciting when you collaborate with someone in a different discipline. It's also an incredible amount of work. We had to learn what ICERs and counterfactuals were, and they had to learn about the context for the entire field of orthopedic surgeons. So the first year of a dozen conference calls at the board level of the Academy, we're just learning from each other about how to communicate. So I'd like to thank my project team. These are all members of the board of directors who worked with me on this project. So here's the problem. Here's Elizabeth Rosenthal, who's writing a series of articles, and there are other authors like her who sort of cherry pick extreme cases and put it on the top of the fold on the front page of the New York Times about how expensive orthopedic surgery is. Cardiology and orthopedics are the big targets. Everybody in the public knows that we have an unsustainable healthcare system, and we need to add value to lower the rise in those costs. How are we going to do that? Well, that means that the people who are responsible for some of those costs are going to become targets for easy answers, and we're one of those targets. So the objective I have in this presentation to you today is to talk about the cost savings of the basic breadth of orthopedics and show you some new research, some new data, and then solicit you as advocates for our profession of orthopedic surgery to answer the critics and at least respond to some of these easy answers. So here's our problem. This is my friend Bill McMaster, a fellow fly fisherman. And the problem we have is the public have a general idea of who we are and what we do, but they don't really specifically understand all of the issues that you as surgeons and as staff understand about our field. And furthermore, because of the obfuscation and the variety of charges and payments, they don't understand, what we get paid. All right? So this is an example of that. Who can tell me what Dr. McMaster is holding in his hand? Well, it's a fish, isn't it? So you kind of know it's a fish. Well, what kind of fish is it? It's a fish decoy. This is used by native tribes over 100 years ago in the northern lakes of Minnesota to fish in the ice. And they would put this fish through the hole in the ice, and they'd bob it around and attract other fish, and then they'd hook fish or spear fish. All right. The second question, though, is what's this antique worth? It's worth more than a total knee replacement, I can tell you that. All right? It's worth thousands of dollars. So that's sort of the problem as an analogy of what's going on with our perception with the public. And our public really have to be our greatest allies. When we argue for pocketbook issues, we're looked at as just self-serving and people who play golf every Wednesday afternoon. Another problem we have is what a lay member of our board taught me, which is that people have a general idea it's a very expensive procedure to have a total knee, and they think we get paid most of the money. All right? So here's what the hospital and the implant company gets, and here's what we get over here. In fact, there's a lot of data now showing that the aftercare post-discharge of a joint replacement patient is greater than what the surgeon and his staff get paid. And so when we get to bundled payments, I expect that will be a huge target for cost savings. This data is really old. This is 10 years old, but it's the most recent data I have, and it shows the burden of musculoskeletal disease to be less than $1 trillion. Let's assume today that it's worth $1 trillion. Kind of hard to get your arms around that $1 trillion figure. To give you some context, the national budget for the United States is $14 trillion. And our national debt is more than that. So it's a substantial amount of money. And the costs are soaring because we have an aging population. This number here, arthritis and joint, look at the staggering increase in cost over this period of time. And it's not going to stop. It's going to continue to increase. We live 30 years longer now than people did 100 years ago. So here are these media attacks, and we are the target. Higher fees paid to physicians, and specifically cardiologists and orthopedic surgeons. This article was published in Health Affairs. And probably most of you in this audience have maybe not even heard of Health Affairs, but this is the journal that all the young policy wonks in Washington, D.C. read, and they're the people who are writing the bills like the ACA. And the bottom line is it says, we conclude that the higher fees rather than factors of higher practice costs, volumes of service, or tuition expenses are the main drivers of U.S. spending, particularly in orthopedics. You feel like you have a target on your back right now? All right. So our hypothesis in doing this study was that when we fix a broken joint and get people back to work, that the net savings to society, or the indirect cost benefit, will far outweigh the direct cost. That was our hypothesis. And that if we could prove that hypothesis, we could change the conversation to how expensive orthopedics is to how cost-saving it is to society. And that's our challenge. The first 20 years I was in practice, I was a road warrior. I was involved heavily in traffic safety issues because when I was 17, I nearly died in a car. And I was fascinated reading data from the feds about what the cost savings is or what the damage is of roadway trauma. If you look at roadway trauma as being a disease, they're able to break down, and I assume that federal economists are not the sharpest tools in the shed, but they could say this is how much the deaths from speeding cost the state of Oregon a year, and DUIs and safety belts. They could break it down in terms of primary risk factors, and then there were these two buckets. There was the cost of injuries and the cost of death, and they were roughly equal, and I was just wondering how in the world they come up with all of this. Well, they come up with that by doing the kind of research that health economists do, and I'm going to show you that you don't have to have a prospective double-blind study. Well, then I called up my college roommate in Missoula, and I asked him if we could do this kind of research. He's a professor of economics, and he said, sure. So we hired these economists, and a year later, they published this article in Cost Effectiveness and Resource Allocation, an online economic journal that's peer-reviewed, and their methodology that I'm going to show you is now, this is the most downloaded article that this journal has ever published. Thousands of economists all over the world have downloaded this methodology and are using it in other fields of medicine today. So this is really a breakthrough thing in health economic terms. What they did was they took basically the CMS does, they survey hundreds of thousands of citizens every year, and they talk to them about their mobility, and they connect that to their ability to be employed and their ability to earn money. And they have published this data for years. And then we took clinical studies in orthopedics using SF-36 scores that connect improvement in mobility, if you will, partial reversal of a disease process, in this case, for example, gonarthrosis of the knee, just sort of the converse of the disease of roadway trauma, if you will. And then they're able to cross-link this data and come up with economic estimates of the value of improving someone's mobility. Pretty interesting stuff. After a year of discussion, we came up knowing that we only had selected amount of resources to do this research, and we picked these 5 conditions. These are all surgical procedures that have a counterfactual. It could be compared to what happens when you do and what happens when you don't operate. And it pretty well crosses a large breadth of what we do, which is a specialty, as you know, with a huge breadth in terms of ages and diseases and conditions. So what basically they're doing with this study is they're connecting physical limitation data with employment and income data. That's what the federal study does. All right. So if you will then, this is income and this is employability. If you take these specific limitations, which I don't think you can see in the back, and you aggregate them, you can see that as people become more impaired, their ability to be employed, their chances of being employed, and their level of income drops. Makes sense? So now how do you quantitate that? Well, we used a Markov model. Let's take total knee replacement, for example. And you have to have different conditions. Not everybody has a perfect outcome from a total knee. We're going to assume that 88% of people have a satisfactory outcome, and we're also going to factor in what the cost is for people who don't. people who have revision surgery, people who have unsatisfactory outcomes, and what does that cost in terms of disability policies and inability to return to work and things like that. So assuming then that not everyone has a good result, we can condition and cost what people have in different states of going through the process of having a total knee. So we can take the direct costs, which are relatively easy to assess, and then we can estimate the indirect costs through other data sets on disability costs and this federal data from the National Health Interview Survey. So then we crosswalk the SF-36 scores from our own clinical data and our own clinical research here with a questionnaire from the survey. And they're almost identical questions. You know, lifting a bag of groceries versus lifting 10 pounds. The scales are different, but with a simple common metric, the economists can neutralize these scales so that they're comparable. All right? And then they take the SF-36 scores, multiply it by that metric, and then they can directly cross-link that data into economics of employability and income levels. And so they take these 3 studies on total knees, and they can say, okay, you've got a 20% chance, increased chance of being employed. Your annual income is going to be $4,500 greater. You're going to miss 6 days less work, and you're going to be 16% less likely to be on disability insurance. Then they add that up, and you come up with a cost benefit. So what we're doing is we're showing if we reverse this decline in mobility and improve people's chances of being employed and improve their average income levels, that's a cost benefit to society. We published this in JBJS. The net benefit per patient is $20,000. Times 600,000 patients done in 2009, that's $12 billion in 1 year that benefited our society. This kind of research has never been published. This is news. This is good news for our profession. But it's only good news if we talk about it and get this to be common knowledge and part of the conversation of how cost benefit our society we offer. And there's a lot of criticism about doing this now in younger patients. 40% of people who have a total knee now are under the age of 65. Well, so, whoops. So here's the 65, so half or 60% of the people are in this group, but the people younger have an even greater, the net cost is roughly the same. The total societal savings is far greater in these younger patients. So there's tremendous leverage there, and that hasn't been talked about. So here's some other articles. Lucina's article showed a cost range more recently, and a similar study showed it a little bit higher, even more recently. But the cost effectiveness ratio, which is for the individual, is another thing. And we could talk about cost effectiveness for the individual, and we can talk about cost savings to the society. Those are 2 separate ways of looking at it. Some of you may have heard about quality adjusted life years, and what Lucina came up with is that the cost for an individual to improve their health was about $18,000 per quality. And that's my phone. And the benefit of that is well below the threshold. For example, in England, they won't pay for anything over $50,000 per quality as a rationing tool. We have never employed that in the US, but I'm just trying to give you some context for the fact that even for an individual, this is cost effective. And then the second article talks about the fact that the probability of heart failure and mortality for those who have had a knee replacement, it goes down substantially over those who do not, who choose not to have the knee replacement. And so that's that's an additional factor that was, I tell patients to call me if they have a problem. That's I don't know how to turn this off. That's a problem for us in that we did not factor this in. We factored in employment and income only. So that's a limitation of our study. So the number, you know, the $12 billion figure, for example, on total knee arthroplasty is only a small part of the cost benefit of people being able to live independently and be less dependent on social services, and also to live longer and have a higher quality of life. We don't include that in our study. So our $12 billion figure is a low figure compared to, but we're, again, so concerned about the credibility of the numbers that we'd rather make conservative estimates and then it's a retrospective study, so there may be some recall bias involved, as with all retrospective studies. Still, 12 billion is a pretty big number. So ACL reconstruction was the second one that we published out of 7 publications that came out of this project. And again, the cost benefit shows that the younger patients have the greatest leverage in terms of ratcheting it up, and we broke that down in terms of short-term and long-term gains, and this is all published and you can read it. And the bottom line there is a $10 billion benefit to society doing ACL reconstruction. So you can't say that these patients necessarily have less degenerative arthritis later in their life, but they're much more able to work and be functioning if they have a stable knee. The next article was on rotator cuff repair. This is also something that's been attacked in terms of insurance companies, in terms of appropriate use. And we're able to show in this study also, all 3 of these in JBJS, that there's a cost benefit to society. It's lower than for the other procedures, but still the net benefit to society is substantial. And we all know of patients that I've gotten back to work for, Les Schwab Tire, and people that are doing heavy stuff that they would never have gotten back to work if they had not had their shoulder rotator cuff repaired. All right, lumbar discectomy. When I showed this research to Kurt Schrader, my representative in Congress, he said that this study made him realize that this is all credible research, because the cost benefits to society is a wash. The cost effectiveness, or the ICER for an individual, is positive. And I'll just leave it at that. Seth Leopold, who published this in Core, wrote an editorial about this research saying that this is good research and it influences how our specialty conveys its value. And the final condition piece that we published, also in Core, was on hip fracture. And again, a huge cost benefit to society. No one would argue, however, that we should be doing hip fracture surgery. So these are all published. And I'd like to spend a few minutes before we close talking about a specific problem that we have here in the state of Oregon. There's a new concept out there that was actually initiated here in Oregon called value-based insurance design. And the idea there is that there would be, just like a copay discourages people from needless visits to see their primary care doctor, that if you charge people more for procedures that are of lower value, that you can save people from having unnecessary expensive care in society. So it discourages low-value care and communicates this through differential cost sharing, and it requires, quote, complex design benefit and adequate appeals process. Well, how could you be against that? Well, this started here in Oregon when Kapowicz, who recently retired, wrote this article, again in Health Affairs, and basically said that Oregon's view of total knee replacement is that it's an overutilized, preference-sensitive Tier 4 level procedure, and that getting a 55-year-old teacher back to work with a knee replacement is such low value that that teacher, for that specific procedure, must pay a $500 copay in addition to their deductible and copays to have that procedure. So that's sort of stuck in my craw. And we sent back a very scholarly response specifically to that article to Health Affairs, which they returned to us in the return mail, meaning the editor did not send it out for review. There is an agenda out there, folks. We were able to publish it in a journal that in economic terms has a high impact called Value in Health. And here's what we wrote. We found that total knee replacement for a working population can generate societal benefits that offset the direct costs. And delay in receiving care because of a higher copayment or other reasons reduce the societal savings of total knee arthroplasty. Well, they don't want to publish this in Health Affairs, but we did get it published. But at the state level now, our former governor was intent on making all insurance go through this type of review. So we've successfully published this material. It's available to you, and I urge you to talk it up. If we put it on a shelf in a journal and no one reads it, no one discusses it, it's worthless. So that's my challenge to you. How many of you have gone to A Nation in Motion online? I'm expecting no hands to go up. Right. This is a public relations site that I want to challenge all of you to spend 20 minutes looking at. It's fantastic. It's robust. It talks about all kinds of patient care. I mean, 600 or 800 different kinds of patient examples. If your patients don't have another patient they can talk to now because of HIPAA, they can look these people up by geography and by procedure type, and they can look up all kinds of information about our profession. And if they go and add the value to this site, they can read the direct original articles. Some people want to drill down and read primary sources now. They're what we call weather involved on the Weather Channel. And they can read about all of these 5 conditions on that site. And there are videos, and there are talking points, as well as direct articles that they can read. And our patients are our best advocates, obviously. So we have used this advocacy, or used this data for advocacy at the national level through the Academy. And again, you can look at this on the site. Our biggest concern doing this research was that if the research was not viewed as credible, that it would cast a bad light in the Academy for doing something that was self-serving and was criticized for methodology, but it has not. It has been accepted as quality research. And we've gotten tremendous amount of unpaid media coverage about this research across the country. But we have to continue the conversation. The industry, this is the device manufacturers. Of course, we're very, very pleased about this information. Dr. Jacobs, the president of the Academy, said basically in his remarks that this isn't just good medicine, it's good business. And this, for businesses who are purchasing health care, this is a message they need to hear. We put this ad, if you will, this message. I have the feeling that the average legislator who's got 1,000 things to think about every day has about a 3-second attention span looking at roll call in the morning. And this roll call message won a national award as being the best in its class. So as I said, I mentioned this and sat down with Kurt Schrader a month ago, and I sent him a 2-page summary of this research, which is available to all of you. If you contact our state office, they'll send it to you. It's great to have everything boiled down to one sheet of paper, and he read it before we met and complimented me on the quality of the research. He was trained as a veterinarian, so he understands the issues with medical research, and he has offered to co-sponsor a letter to CMS bringing attention to this research to them, but there are many other decision makers who need to be aware of this research. And again, I challenge you in the networks that you have with payers, decision makers, patients, elected officials to give this information to them, because when the decisions are made on how we get paid, having this information in the back of their mind would be very valuable to us. It's a society that responds to information. Graham Newsom, our director in our Washington office, would be very happy to help you with talking points, with advice and information about this research, so that you can facilitate making your time as an advocate most effective. So in summary then, our procedures are cost effective. We need to have the media, the payers, the policymakers aware of this research and that this is new information. As Abe Lincoln said, as our cause is new, we must act anew. And we must act on this information to counter the media agenda that we're facing now. So it's important. All right, so if any of you would like to contact me specifically, I'm also happy to talk to you about this and be happy to answer any questions. I think we've got a few minutes for questions if anyone would like to challenge me. No. I apologize about my phone, by the way.
Hey, this is the first time I've seen anything about this. I mean, most of the time when I read articles, it's always how horribly expensive it is, and it'd be really nice if this was, I guess, more in general media too. Maybe it is, I just haven't seen it.
You know, I think there's two ways to do this. One is to take some of those media reports and write a response, and you have data now. Another is to be proactive and write a letter to your local paper saying that you're sick of reading these negative reports about what we do in American medicine, which is the best in the world, and here's some specific examples. Another is to, you know, when you hear that someone with influence is having a knee replacement, is to write them a personal letter saying, I'm glad you had access. Here's what it means to society in general, and I'm wanting you to understand that. I think these are all opportunities. Our patients are our best advocates. If you know, I don't talk to my patients about money. I try not to look to even see what kind of insurance they have, because I don't want any unconscious bias to affect how I treat my patients. But if patients tell me, and they bring this up, particularly Medicare patients now, when they look at their EOBs and they're saying, I can't believe how little you got paid for this procedure, and how big the hospital bill was, then you can have this information available and give it to them, and they can be your best advocate. Our patients are we also have incredible credibility one-on-one talking to people. People still, we're still the most respected profession in America. And if you have a one-on-one conversation with an elected official and you're reasonable and you're prepared and you have data, they need data. And that's one of the things that Schrader kept saying in our conversation, is how desperate people in government trying to make decisions are to have good data, good information.
Do you feel like it would be too self-serving to provide that information in your pre-op packages?
I think it's well, I'd like you to see the sheet. I'm sorry it wasn't in your packet. It took me 3 months to write it. I think Adams wrote to Jefferson once and apologized for the length of the letter, said I didn't have time to write a shorter letter. And it took me a long time to get everything onto one sheet of paper, but we can get that available to you, and then you can just see if you want to take excerpts of it or if you want to include the whole sheet. But I think it's a powerful statement to show in summary and cite the references. I mean, this information is published in the 2 top orthopedic journals, top 2 or 3 in the world. And you could say, well, yeah, it's published by orthopedists for orthopedists and it's self-serving. But let me tell you, the reviews that we got on those 5 publications were extremely critical. The first reaction to something new by a reviewer is, we don't want to publish this. But because the research was rigorous and because it was carefully done and carefully worded so that it's not showing obvious bias towards our profession, it was accepted on sometimes multiple reviews. So I think it's really important that we get this information to patients. I like your idea of trying that with some patients. It may not work for all patients. I don't want to offend anybody, but I do think that it's democracy. We have to talk about issues. I worry that we're just getting billionaires and corporations running our elections in the future. We have to have more of a grassroots interaction. We're all extremely busy people. Everybody in this room is extremely busy. But if we don't pay attention to these things, as Alan Simpson, a famous senator from Wyoming, once said, if you're not at the table, you're on the menu.
So,
It's already happened. We're already posted, right? It's already happened. We're already posted.
How many of you feel that you're in private practice?
So the model, the value-based model that went into effect for the state of Oregon employees is being brokered to large employers in the Portland area really aggressively. How much dialogue is, or what vehicles are using to continue the dialogue as this model is being replicated at the state level with the insurance commissioner, with some of the large carriers, for the information that we now have, and like this asset, about the economic impact of some
Right.
of these decisions.
Well, who do you know that you'd like to talk to? I'll come with you. I know Sharon Saxton, and I'm looking forward to meeting her. She's the new chair of the Oregon Health Authority, and there are a lot of conversations there that we need to have, and there's a lot of momentum for this value-based insurance design. It sounds very attractive. People are looking for an answer, and here's a apparently nice-looking solution. You look back and read Kapowicz's article, it sounds like 3 or 4 people made this decision without any feedback or without any peer review, and certainly without any public discussion. I've heard the same complaint about appropriate use decisions being made in the state of Washington, that they're made by a small group of people who don't know our field, who read some articles. One of the reasons we had all of this conversation with the economists was if we had just told them to write about this, it would have been like assigning a medical student to writing a chapter in an orthopedic textbook who read a few articles and tried to come up with a context for an area of our field that, with very little background. That's what's happening in terms of trying to apply this type of design. And they just need some feedback. And now we have data to give them. And I think that thoracic surgeons and cardiologists also have data, and that's critical. They're going to need that to protect access to that kind of health care as well.
It almost feels like the dialogue might need to be expanded through some of the arms of some of the chambers or business associations that look at healthcare. And there are, because of the cost of healthcare, of course, there are arms of chambers of commerce that do center around health issues. So that would be a vehicle as well.
Those are great thoughts. And you know, Dr. Keenan here is our president, so I'm sure if you'll talk to him at break, he will follow up with you. Right, Tim? All right. Nan?
I just wanted to say that we'll ask OAOE to email out the one-page summary.
Great.
And then also you can get it on our website at OregonOrthopaedicSurgeons.com. Just click on A Nation in Motion, and it's there, and it's downloadable as a PDF in color.
Yeah, it's got some graphics. It really presents well. And they can, another way you can do that is if you specifically want to talk about one of the procedures, you can also download the original article and put the summary sheet on top of it, and that's an even more impressive package. And probably the member of Congress won't read it, but their staff will. And again, your influence can be, well, we've never had anything before. We'll see how impactful it can be. But now that we've worked for 5 years to publish this information, make it available, the challenge now is to make it useful. Okay.